Welcome to the Cataraqui Woods Dental Implant Institute, a nonprofit organization dedicated to furthering both education and research in the field of oral implantology. My name is Dr. Waji Khan. I am a dental surgeon and also the course director for a series of online lectures provided as a service to the profession of dentistry to deliver a literature and knowledge-based approach to dental implant education for practitioners interested in learning more about how to implement the discipline of oral implantology into their clinical practice. This online course should be merged with a suitable clinical course and long-term mentorship study club program so that the learner can maximize their benefit from the didactic online program. The production of this series of lectures was partially funded by an educational grant from the International Dental Implant Academy. Lecture 7, the post-surgical follow-up. So basically, in terms of post-surgical follow-up, we generally like to see our patients shortly after we operate on them. The first slide we're going to talk about here is healing time. And healing time is something which is kind of confusing. For many students who are studying oral implantology, they'll come to us and say, well, isn't it about 6 months that it takes for implants to heal? Some patients come to us and say, well, isn't there like an immediate dental implant you can do and give me a tooth that I can function on and eat a candy apple on the same day? One of the things we need to understand about healing time is generally this has become one of those things where everything you try to push the envelope or push the limits further. So classically, the details for healing time come from orthopedic surgery. For those of us in healthcare, it's a bit of the blunt end of a joke is that orthopedic surgeons aren't very smart. They're very intelligent people, but what they say that orthopedic surgeons like to work in sixes, so everything's 6 weeks or 6 months. Dr. Peringvar Brandemark was an orthopedic surgeon, and so the classic studies that we did for implants was to give bone 6 months to heal. So we know that most of the time when people have a fracture, like a fractured leg or a fractured arm, we generally have them splinted for about 6 weeks, and we know that there's going to be a fairly mature callus and that the bone's going to be healed fairly well after 6 weeks. But we do know from the classical studies that it takes about 6 months for the bone to get to a point where it's completely healed. So that's one of the reasons why the 6-month mark was selected as the amount of time to take from placement of a dental implant to actually doing the stage 2 procedure to loading it with some sort of a prosthesis. With this in mind, a lot of people went to what they would call early loading, so say going to something like 6 weeks, or some people even went to going to immediate loading, whereas you basically place an implant and are able to fabricate some sort of a temporary abutment into a tooth and give the patient a tooth on the same day. With this in mind, basically what it comes down to is what can you, going back to our principles of biomedical engineering and talking about that principle of dynamic reciprocity, what are you asking the body to do and what's the body going to do to the implant? So in a patient who's a severe bruxer who doesn't like to wear their bite plate and who has fairly large bony voids after taking out teeth and placing implants and bone grafting and stuff, you may want to consider giving this person 6 months of healing time prior to loading this implant with a healing abutment and progressively training that bone using Wolff's Law to get it to heal. Whereas for somebody who's perhaps not fitting into this boat and you're able to put an implant in for a patient and you have good insertion torque, you may want to consider placing an immediate loaded transitional or temporary tooth onto this particular case, making sure that the patient doesn't have any working contact, and instructing this patient that they're allowed to eat with this tooth whatever they can eat with a plastic fork or a plastic spoon, not a plastic knife. This is something which was recommended to me. Or even in terms of going back after, say, 6 weeks when that initial healing is taking place and try loading the implant. So a lot of it comes down to sort of a gut feeling when you're placing the implant, when you think that this implant's going to be able to be loaded. We also know that when you place an implant, a lot of times we'll place an implant and it'll be in there with a great exertion torque and great lateral stability, and we'll be like, wow, why can't I just load this now? Well, what you need to realize is that from that point of injury, what's going to happen is there's going to be an inflammatory cascade that's going to take place. And if you were to go back and say about 3 weeks later, you'll find that implant at about 3 weeks, 21 days, and it's when it's probably going to be the weakest sort of tissue around it. So just because it goes in very firm doesn't mean that 3 weeks from now it's going to be the similar firmness when you try to apply a load to it. So just some things to keep in mind. Going to the next slide, we basically want to verify when we bring patients back in for this post-surgical follow-up that the dental implants have integrated by both clinical means and radiographic means. So clinically, generally what we do, we talk about something called the Austell implant stability quotient, or basically you should be able to, between your own two fingers, by placing something like a impression coping onto the implant, determine if there's good lateral stability. And radiographically also, you want to ensure that there's no soft tissue that is sort of formed. Sometimes you take a Cataraqui, you'll see black lines. These are mock lines. Generally, a periapical radiograph is the most sensitive when it comes to being able to actually seeing that bone has healed in and around your implant your implant grooves. So communication with the surgical dentist may be required by the person who's seeing the patient post-surgically. And you also want to evaluate the location and the angulation of the integrated dental implants in relation to the remaining dentition and the suitability of these to support the desired prosthesis. As we talked about in the treatment planning lecture, generally we don't want to get to a point where we're saying that the location and angulation is not ideal. As we discussed earlier on, implant dentistry is a prosthetically driven surgical discipline. So to say that you're evaluating things at point C and things aren't good, that's not necessarily, that's not a surprise that you necessarily want to find or have to discuss with the patient. Consideration should also be given at some point in time, and this is usually made at the treatment planning stage, but for the use of a transitional prosthesis, and consideration for this should be given if there are concerns about the dental implant's ability to support the desired prosthesis, if there are highly challenging functional and or aesthetic demands, and if there are significant changes that are going to take place to the occlusal scheme. And the time for the use of this type of prosthesis can be upwards of 6 months. Something like an orthotic as compared to using something like a bite plane may be better in terms of being able to provide more comfort for the patient, less impediments in terms of speech, better function, better aesthetics, and a better clinical data point to provide to you in terms of whether this is going to actually work or not. We'll talk a little bit more about creation of these orthotics in the prosthetic phase lecture. So post-surgical checklist, basically patient comes back to see you. So generally I like to see patients usually at the 7-day mark. Some patients will come back at 6 months. Some patients will come back at the 6-month mark. Sorry, did I say 6 weeks? Sorry, I meant 7 days, then they come back at 6 weeks, and then, or if not 6 weeks, they'll come back at 6 months. So generally you want to confirm that normal healing has taken place. So you don't want to see any cardinal signs of inflammation or infection in these patients. You want to ensure that swelling and bruising has been resolved. You want to ensure that any sutures that were placed have either dissolved if they were resorbable sutures, or if they're removed if they were non-resorbable sutures. You want to ensure that there's the absence of pain, infection, or paresthesia. You want to ensure that the dental implant and the abutments, if they were provided, are stable. You want to also ensure that if there was a transitional prosthesis used, that it's sustained comfortably. And you also want to ensure that radiographs will confirm good implant position with steri-peri-implant bone. And then finally, if it's the case that you are not the surgical and prosthetic dentist, you want to make sure that there's a report provided to the prosthetic dentist that's prepared and sent. So let's take a look at a case here in terms of what we want to see for patients from a post-surgical perspective. We'll talk about the case, but basically what we're focused on here is what the patient comes like from a post-surgical perspective. So we have a 47-year-old healthy female that presents with a failed fixed partial denture from the 1-2 to 2-2. It's noted that the midlines for this patient are off, and she basically wants a more aesthetic result as she works in the public service. So in terms of discussing this case, let's take a look at this. So more or less, you can see from this photograph here, you can see that this patient has a failed prosthetic. You see a fracture line right through that porcelain between the front two teeth. You'll also notice that the midline is off, and this patient also has some sort of a flexible acrylic partial in the mandible. So when we take a look at this from the occlusal perspective, you can see that more or less this patient is basically missing one of her teeth. They've sort of creatively taken one of the premolars away, and sort of she has some shifting of these eye teeth towards one side, and this is basically taking her maxillary midline off to the side. So when we take a look at this radiographically, you can see that this patient basically has her eye teeth, but some of the premolars were taken away prematurely, and as such, she's had some shifting going on. So in this case, with the failed bridge, you can see that there's some caries going on with that upper right lateral incisor. That the best option for this patient is going to be probably removal of these lateral incisors and provision of some sort of an implant solution. So from her perspective, she opted for an implant solution as compared to going with a 6-unit bridge or removable partial denture, or no option, which really wasn't going to address her chief complaint. So in coming up with a treatment plan, we basically got a consent from this patient. We got some study models, we got some photographs, we took some intraoral records, we got a diagnostic wax up in order to display to her what things were going to look like from an aesthetic perspective, and we'll take a look at that right here. So part of the study models, we take these with this record of her interpupillary plane and also her midline, and convey this back to the lab, so that the lab, when they send us back the diagnostic wax up, can sort of have an idea of how we can shift that midline over and give this lady what we call the golden proportions. Going back to the treatment planning lecture where we talked about aesthetic dentistry, these are basically taking principles of aesthetic dentistry and bringing them to our treatment planning stages for dental implants, so that when we're going to be placing implants for this patient, we can keep all this information in mind and basically place the implants in an ideal position so that we can maximize the aesthetic result for the patient. Going to the next slide, going back to the treatment plan. So basically it's going to be removal of the failed FPD, atraumatic extraction of the lateral incisors, the placement of 4 osseointegrated dental implants. We're going to place some bone graft for this patient as well in order to address some of the gap jump junctions, and we're also going to be placing some platelet-rich fibrin, which you're going to see is going to really augment the soft tissue healing around these dental implants. And then we're going to insert a removable acrylic partial upper denture for this patient, and then the patient at the end of the day is going to have 4 implant-supported crowns in the anterior maxilla, along with a crown on the 2-3 to make it look like a lateral incisor, and we're going to basically make the 2-4, or the premolar, sort of look like a cuspid. Basically what we're going to be doing is we're going to be correcting this patient's midline by making it look like she did not have premature loss of that premolar earlier in life, and that shift that basically was dealt with using her existing fixed partial denture, and basically trying to correct for years upon years of basically patchwork and try to make it right from our treatment planning perspective. So taking a look over here, we basically section that bridge off, and we're able to get a lot of the just broken segments and stuff off for her. And then we were able to atraumatically extract these teeth and raise a flap to basically expose the bone that we wanted to use as the foundation for our implants. We also try to ensure that we have we maintain that the buccal plates remain intact, so as to not cause any problems from a buccolingual bone loss perspective. As you can see in this patient's case, she has tons of bone. So 4 implants were placed in position at good insertion torque. You can see the gap jump junctions that exist on the buccal aspect of those eye teeth. So those areas were grafted, and some platelet-rich fibrin was put into place, and we're now going to suture this patient together. And this is what the patient looked like when the patient left our inserted a transitional partial denture for the patient, but what the patient looked like from a surgical perspective the day of the procedure. So what I'm going to show to you now, and if you haven't been convinced of using platelet-rich fibrin before, is this is what the patient looked like 7 days later. And you can see that this tissue looks great. This tissue looks awesome. Despite the fact that we use silk sutures, a silk continuous locking suture in this case, this patient looked great. She basically said she had no pain, that basically she felt like nothing had been done. This is, I mean, obviously her own pain experience. The sutures were a bit uncomfortable, but she was happy to have them out. So a little trick for those of you who haven't really taken any formal surgical training in terms of removing sutures, you basically want to cut these things off at the base. So in the next picture, you'll see what I mean by cut it off at the base, because what you don't want to do is cut them off in the middle like many people do, and then have to wick that bacteria that's sort of been sitting on these sutures for that period of time that they were inside the mouth, and wick that through your healthy tissue and basically inoculate the tissue and cause infection. So that's how you want to sort of take it off. And in the next picture, you'll see that after sutures are removed, this is what the tissue looked like. Unfortunately, this case is still in the healing process, and I don't have any final photographs for it, but I can assure you that in the later on lectures, I'll try to include a picture of this case just so you can see what the final result looked like. So platelet-rich fibrin, if you aren't convinced about it yet, let me try to sell you on it. We've talked about the miracles of platelet-rich fibrin. So here's a case we did for a patient where basically we removed all the mandibular teeth for this patient and placed 2 dental implants, some platelet-rich fibrin, some bone graft, and the end state for this patient was going to be to get some locator attachments for a complete lower denture. So we took the teeth out, and as you can see in this photograph here, we've jammed some platelet-rich fibrin in there, sutured it in with a 3/0 silk locking continuous suture, and the patient was supposed to get a transitional denture on this date. And unfortunately, the denture wasn't at the office. So, surprises in implant dentistry never being a good thing. I had to apologize to the patient. I'm sorry, transitional's not here. Can you come back tomorrow? So I don't usually see my patients a day later, but a day later, this is what the tissue looked like. Amazing. This is platelet-rich fibrin. I mean, basically, it's clotting the patient's own blood and providing them with a super clot, concentrated growth factors. The patient told me she had no pain. The area felt really good. This tissue, I mean, it's minimally inflamed. This looks like she didn't have surgery done. So this is a day later. And this next picture, this is 1 week later, okay? Once again, remove these sutures. This patient healed without any complication, without any surprises. What this case is also currently healing, and we're going to bring this patient back and put some locators on for her. Still not convinced. Okay, how about another case? Patient came in, so surprise cases. So patient came in to see me for a crown prep, and this is how he presented. And I said, okay, let's see here. So there's no ferrule here, as you can see in the clinical photograph, and more or less, this was a crown that had been placed by a colleague of mine, and the crown had failed after a year. Well, I wonder why it failed. There's no ferrule. So more or less, I had to have the difficult discussion with this patient with respect to, okay, we more or less said, there's not really much I can do for you. It's either a 3-unit bridge or partial denture. He said, why don't you just put an implant in for me? I said, okay. So we treat implant a case for him. We said, okay, atraumatic extraction. Take this tooth out, get an implant in, put a bone graft in, and some platelet-rich fibrin. So let's just quickly go through this case here. And once again, here from the occlusal shot, you can see that this is what was remaining with respect to this tooth, that there was absolutely no ferrule. We'd have to do some sort of a crown lengthening procedure on the buccal aspect of this tooth in order to restore it. Well, why are we going to do that and cause problems for him with the other teeth? So we atraumatically took this tooth out, and there's the tooth for you in this picture. And there's the residual socket, and we were able to basically go into the dense palatal bone and maintaining a screw retained position, place a dental implant into that palatal bone, and we grafted the buccal gap jump junction with a allograft. The same thing I always use, mineralized 50-50 chordocancellous, varying in particle sizes. In this case, we use a smaller particle size graft, and basically cover that up with platelet-rich fibrin. This patient was also a patient who, it was a surprise case. We weren't planning on doing this day, so I didn't have something ready for this patient this day. I said, okay, you need to come back and see me tomorrow. My assistant, my astute assistant, had basically taken an impression of this patient before we started anything. We mocked up a tooth there using some composite for the impression, and we made this gentleman an Essex retainer. If you've never used Essex retainers, I'll show you what they look like. They're really neat. They're kind of like Invisalign trays, but you end up putting a little bit of a composite tooth inside the area where the tooth used to be. And what this does really nicely, it puts no pressure on the tissue. It's an easy way to give a patient a transitional or some sort of a flipper without basically costing them a lot of money. So this is the PRF in place the day of the procedure. The next picture here, this is what the patient looked like 24 hours later. So you can see this beautiful white fibrin clot. Do you see any signs of inflammation? Do you see any signs of infection? Any redness? No. Any color change? No. Any inflammation? Any swelling? Any loss of function? I mean, there's nothing. This patient told me he had no pain at all. He wasn't even taking ibuprofen, right? This stuff is just amazing. So if you're not convinced about PRF, I'll tell you, it's probably one of the coolest things I've seen in dentistry in my entire career. We use this stuff routinely every day. Some people out there argue that this stuff is hocus pocus. It doesn't do anything for you. Well, you know what? I don't consider what my patients tell me as hocus pocus. I don't think that the studies out there that state that PRF augments bone healing are correct. There are some good PhD studies that I've read. No, there's no effect on bone healing. But in terms of soft tissue healing, it is truly the cat's meow. So here's a picture of the patient with the Essex retainer in. So as I mentioned, it's just basically like a glorified, whitening tray or Invisalign style retainer, and you just put a little bit of a composite tooth in there, and it helps restore self-esteem for the patient. And a lot of patients wear Invisalign these days, so as opposed to walking around people saying, hey, is that a fake tooth, people just say, hey, are you wearing an Invisalign tray? And normally most patients just shake their head and just say, yeah, I'm getting some treatment done. So checklist for the confirmation of osseointegration. So before you can going to consider anything from a prosthetic stage perspective. So assuming that this is the end of the road for you, you are the surgical dentist and you don't do anything pros-wise, you fired your letter off to the guy restoring this, what do you want to confirm? You want to confirm, number one, that dental implant stability has been confirmed. Number two, you want to ensure that there's an absence of pain in this patient. Number three, you want to ensure that the peri-implant soft tissues are healthy. Number four, you want to ensure that radiographs confirm stable peri-implant bone. Number five, you want to ensure the patient is appointed for a prosthetic restoration. And lastly, that a report to the prosthetic dentist has been prepared and sent. So the next lecture is going to be about the pre-prosthetic assessment, and in this lecture we'll sort of also cover some techniques that are used for stage 2 procedures as well. Once again, I've included a number of the references that we used in the production of this entire course. And on behalf of the entire dental treatment team at the Cataraqui Woods Dental Implant Institute, I want to thank you for listening to our lecture.